Hello, everyone. My name is Natalie Dickey, and today I am going to be presenting on major depressive disorder, also known as MDD. All right, so let's begin. So some facts on major depressive disorder, or just depression in general first, sorry. Depression is a common mental disorder. In fact, our textbook describes it as the common cold of mental health. In a study that I read about, it said that depression is a prevalent psychological health condition, and clinical diagnoses such as MDD are associated with significant burden for patients and society. So, patients obviously suffer a reduced quality of life, but in terms of society, there's definitely some direct and indirect challenges with those who are suffering from depression. So, maybe a lower productivity, increased prevalence of other conditions, increased healthcare cost, and it has the risk of being passed down to children or in generations to come. So, we'll talk about all of those in a little bit. Globally, more than 264 million people of all ages suffer from depression. And depression is the leading cause of disability worldwide and is a major contributor to the overall global burden of disease. So just kind of some worldwide statistics with depression in general. And then we're going to continuously come back to the risk of suicide and depression. So I thought it was important to add these statistics here just so you know how important it is to continually assess your clients for suicide ideations and harm to others. So 800,000 people die from suicide each year. It's the second leading cause of deaths between 15 to 29-year-olds, with, I think, car crashes being the first. And 50% of depressed patients make at least one suicide attempt during their lifetime. So got that from a different author, but kind of a big stat there, kind of a big fact. There are different types of depressive episodes. Today I'm focusing on major depressive disorder, but it's good to know that there's different types. According to our textbook, all have the same characteristic of having cognitive, somatic, and emotional challenges reflecting feelings of extreme sadness or irritability. So again, just kind of a common characteristic as a whole in depression. And there are psychological and pharmacological treatments for depression. So what's different than between all of these depressive episodes? Well, the duration, timing, and the cause of the illness can all be different, as well as the interventions. So so it's important to know the different criteria. So moving into the history of depression, the first written accounts of depression were during the second millennia BCE. At the time, they viewed it as more of a spiritual condition, rather physical than physical. So people would call the priest to let the demons out, and there were beatings, physical restraint. This was prevalent in many cultures: ancient Greeks, Romans, Babylonians, Chinese, Egyptians, and even ancient philosophers. However, there is some evidence that some Greek and Roman doctors saw it as a biological and psychological illness. Again, moving into the Middle Ages, Renaissance, there's always this distinction between religion and mental illness. So again, attributing it to the devil, demons, witches. We have exorcisms, drownings, burnings, were popular treatments. We have insane asylums, witch hunts, executions. So all things very common during this time. Robert Burton came out with his book in 1621, The Autonomy of Melancholy, and so referring to melancholy as depression. And in his book, it outlined the social and psychological causes of depression, such as poverty, fear, and loneliness. And he made specific recommendations like diet, exercise, travel, purgatives to clear toxins in the body, herbs, and music therapy. So it's, one of the first books that kind of talks about treatments and that maybe it's not connected to the devil. And then we go into the Age of Enlightenment. Depression is still viewed as a weakness, with that stigma following it. Different thoughts were that it was inherited, it couldn't be cured. People suffering from depression should be shunned, locked up. But doctors begin looking at depression as internal conflicts between what you want and what you know is right. And then going back to treatments such as exercise, diet, music, talking about problems with your friends, maybe your doctor, which I would think would be challenging for many people, knowing its stigma that it carried. Ben Frank developed early form of shock therapy during this time, so important to know. And all of this is coming from this article down below, The History of Depression. Still continuing with the article, we have Sigmund Freud in 1917, where he wrote about melancholia, and we've taken theories. We know that psychodynamic theory was developed during that time. And then German psychiatrist Emil discovered that manic depression, now known as bipolar, was actually separate from schizophrenia. So this is pretty a big separation. We're going to talk a little bit more of depression being separated as a whole. But at that time, it still was mixed in with bipolar disorder, but he did separate it from schizophrenia. Some doctors begin to see it as a brain disorder. Freud actually theorized that it was a response to loss, either real, for example, such as death, or symbolic. So, for example, failure to achieve a desired goal. So that's kind of how he saw it. But we move into behaviorism, where many believed that depression was caused by unconscious forces and suggested that it could be a learned behavior and therefore can be unlearned. And so we have association, reinforcement, we have the cognitive theories, Aaron Beck, Martin Seligman, CBT coming out of that, where people often give up trying to change their situation because they feel that nothing will make a difference. And so they kind of define this as feeling helpless. So people felt helpless. And Martin actually coined that as learned helplessness. So we have some of those definitions. 1970, the medical model actually was the first to suggest that it was caused by psychological factors and that it should be viewed as a mental health condition, just like physical illnesses, which means that it could be treated with medication. And so that's where medication started coming into play, and also treatments like lobotomies and electroconvulsion therapy, lobotomies, surgeries to destroy the prefrontal lobe kind of did have a calming effect, but they found that there was a lot of personality changes, loss of decision making, poor judgment, maybe even death, an electrical shock in the scalp was used in electroconvulsive therapy, also sometimes used for patients with depression. So there was a discovery that azid, I want to say, helped those with depression. It was actually a tuberculosis medication, and they found that this was actually helpful with those suffering from depression. And then we have the development of other antidepressant, or antidepressants. So medicine definitely became in the mix during this time. Um, Major depressive disorder was introduced by clinicians in the 1970s, and actually became a part of the DSM in DSM-3. So that's kind of when it kind of came around. 1980 was the DSM-3 when MDD was included. Moving forward with depression, it's obviously better understood today than it was in the past, but researchers are always looking to learn more. At this time, doctors believe depression arises from a combination of multiple factors: biological, psychological, societal factors. So just more understanding of depression, more evidence, more research always coming out. So kind of cool to see the movement. So the DSM and depressive episodes, I told you there was kind of a trend of separation. So before the DSM-5, depressive episodes was actually included in the bipolar chapter, bipolar and related disorders. So in the DSM-5, it was the first time it separated the disorder and looked at as separate. And so this was to assist practitioners in noting the degrees of severity, and can take into account the overlapping symptoms. And so, kind of interesting to now see it as its own chapter. And they included two new disorders. Well, two disorders were now included in the DSM-5: disruptive mood deregulation disorder and premenstrual dystrophic disorder. So, again, I'm going to be focusing on major depressive disorder, but just kind of cool to see how far depressive disorders has come and now is its own category. They did take out of the criteria for MDD. We're going to talk about the different criterias, but just know there was a criterion E before. And in the past, symptoms related of a death of a loved one could be counted only when symptoms persisted longer than 2 months. And other things that you can read here from our textbook, page 253. But there was a lot of argument about this, for and against. So whatever the reason, MDD diagnosis would be postponed after a 2-month period when it was related to bereavement, death of a person. So there's no longer that 2-month wait. So that's kind of a change in the DSM in terms of depression and MDD. So moving right along with the different criterias. So this is specific criteria for major depressive, major MDD, major depressive disorder. And the other ones have their own specific criteria, but I'm going to just focus on this criteria for MDD. It's characterized by a single or recurrent major depressive episode. So it could be one or it could be many. There are 9 primary symptoms, and an individual must have at least 5 of them. But of those 5 symptoms, a depressed mood or loss of interest or pleasure must be one. So they're actually the first 2 criteria, and they have to be included within the 5, one or the other. So interesting to know. And they all must occur within a 2-week period, with an exception of one, which we will talk about. This is all from the DSM-5, so directly stated that you could find. So going into the criterion, depressed mood needs to be most of the day, every day. A clinician or a counselor can use it as a self-report from the client or an observation made by the clinician or others. So just looking at feelings of sadness, feeling lost, isolated, alone, empty, hopeless. And just knowing that there was a lot of discussion on children and adolescents. And so, with all these feelings, children and adolescents may present anger or irritability. So, just being aware that those signs may show in this way. Um, this is from our textbook, and we will explore self report and direct observation in a little bit. But I just wanted to put that in there that this is how you can assess or gather information. Another criteria marked diminished interest or pleasure almost all the time, every day, self report, direct observation, or observation by others. So, again, of the 9 criteria, this one or this one must be included within the five of your client's assessment. Appetite changes and waste loss or gain. So this is the one where it must be actually examined over a month time frame, not 2 weeks. So if you're including this criteria within the client's diagnosis, you must have evidence of a month time frame. So it must be a change in weight when the client is not dieting or trying to gain weight. And so, over a month's time, a change of more than 5% of body weight should be noted. And that's straight from our textbook. And then it's important to also, look into anorexia or hyperplasia. And so, anorexia meaning eating less or not eating at all, or hyperplasia due to overeating. So, is the client suffering from these things? Important to ask. Other important questions that you could ask or use as your little assessment: has the client gained or lost weight within the past month? If so, how much has been lost or gained? And just really documenting this is important. Another common criteria or common symptom is sleep disturbance. So we have symptoms of insomnia or hyperinsomnia. So insomnia meaning difficulty falling asleep or difficulty being in uninterrupted sleep. Hypersomnia, trouble, excessive sleepiness. So just sleeping more than the average number of hours. I actually had a client who suffered from hypersomnia, and it was that she just couldn't get up. She would sleep through the night, she'd sleep all day. And so things, just to be aware. Obviously, it should be documented. Questions to ask: is the client sleeping at night? If sleeping nightly, for how long? How does the client feel when he or she wakes up? Do they have feelings of being refreshed when they wake up? So you could kind of gauge where your client's at with that. Our textbook really discuss disturbances of eating and sleeping as common and are often assessed first since they are basic to survival. So it also stated that clients could be considered vegetative, and that's the language they would use: insomnia or loss of appetite, or reverse vegetative symptoms. So hypersomnia, oversleeping, or hyperplasia, overeating. So that's straight from our textbook. Other different criteria of the 9: psychomotor agitation, so extreme restlessness, and the individual feels as if he or she cannot calm down. It's important to know, is this also due to medication or substance use? So just asking questions like that. Fatigue and loss of energy, so no energy to complete basic tasks, like even taking a shower is challenging. And feelings of worthlessness or guilt. So these things are really magnified when they both persist. Feelings of loss of energy and feelings of worthlessness. It's just very magnified when they're coupled together. Within the feelings of worthlessness, I thought it was important to note that there could be delusional thinking, where an individual remains convinced that his or her thinking patterns are logical, even pointing out that the reaction is beyond what is expected. So that's just taken from our textbook. And again, I felt that was worth noting. We'll talk a little bit about that because it kind of all flows, but diminished concentration and indecisive thoughts. So the inability to concentrate and problem solve. Um, Again, self reports would be good. Clients or other observations are good. Recurrent thoughts of death, discussion of self harm that may or may not be related to a specific plan. So, going back to the suicidal facts, I think it's very important to kind of always be assessing your client's safety for suicidal ideation or harm to others, just because, as you see, these all flow with the delusional thinking, irrational reactions. And so always assessing, before, during, after for those risks is so important to your client's safety, especially when they're suffering from MDD. Other additional criteria taken straight from the DSM-5, you can see that on page 161, but clinically significant distress or impairment in social, occupational, or other important areas. Um, Again, children and adolescents, you would see the mood is irritable and it may be presented differently than an adult. The episode is not attributed to psychological effects of substance or other medical conditions. And then this occurrence of MDD is not better explained by other disorders, schizophrenia, bipolar. And then there is no history of manic or hypomanic, of a manic or hypomanic episode. So just taking into the thought that it's now separate. So MDD is considered a separate disorder apart from other mental disorders. So it's always important in the assessments to be looking at other disorders too and those qualifiers. And we will go more into depth with that. So, methods for making a diagnosis. I think it's important to determine if it's this, or both. Endogenous melancholic depression, symptoms related to internal biological factors. So, is this being passed down? Is this a biological situation? It's really going to help your interventions. Exogenous environmental depression related to external or environmental causes, and current stressors. So, is there a current stressor that had happened in your client's life? Death to them, loss of a job, etc. So keeping in mind what's normal and what's not normal, in an event of a death of a loved one, grief and sadness are normal feelings. However, isolation, feelings of worthlessness, guilt, wanting to die, those things are, not normal. And so that's when you'll start kind of assessing brevement versus major depressive episode. Because remember, it could be one big episode or it could be reoccurred ones. So maybe this is a one episode, or maybe it's both. And again, this is really just helping your interventions. These are taken out of our textbook. Methods for making a diagnosis. So assessments are always good. I think back to my intakes, and that's always a vital part to beginning therapy. And, I put what should be included in these assessments. So, in an article that I read by Grobler, he said it's important to know the history of the illness, current symptoms, past psychiatric and treatment history, client's response to those treatments, general medical history, history of substance abuse, personal development history, response to life transitions, major events, social, occupational, and family history. Family history is very important. We'll talk about that. current mental status, physical examination, and of course, there's always that suicidal and homicidal assessment risk that we should be asking in every session. So other methods for making a diagnosis, our book talked about self-reporting, but it also discussed its challenges. Practitioners need to qualify client symptoms. So for a client to say I'm sad or blue, that's challenging to qualify. And it could be frustrating for your client because they're suffering from depression and it's hard to qualify the results. Then it may mean a lack in diagnosis. So, we got to be very careful with these self reports because the depression could be overstated or it could be understated. It's a subjective experience that the client is discussing within their social, cultural, environmental context. So, our book actually called for these self reports to be clear, concise, psychosocial criteria based diagnostic standards that should be being addressed within these self reports. So we'll talk about different assessments, but I felt that that was important to discuss the challenges with self report. Direct observation by the clinician is always good if the clinician has the ability to observe the client in a social setting and observation by others. I'm just going back, I do remember discussion of home visits, and that might be a thing here. Observation by others, family, coworkers, friends, and the specifics. And again, just going back to qualifying. So when we're getting these observations from others, getting specific evidence of this, factual evidence that the client has a loss of enthusiasm and activities. So very important. Our book stated this quote, I thought it was good, that to achieve the most comprehensive report, both self report and observation are recommended. Other methods for making a diagnosis. This is all taken from Grobler's article, Major Depressive Disorder. He suggests for clinical diagnostic assessments that incorporates different diagnoses, and we talked about why it's important to ensure that our client doesn't qualify for other, diagnoses as well. Measurement-based diagnostic tools assist with the assessment of severity. So should be in addition to the assessment, presence of co-occurring disorders and that suicidal risk. So, some disorders he thought, should always be incorporated in these assessments were bipolar disorder, adjustment disorder with depressed mood disorders, due to a medical condition, and substance abuse mood disorders. So always just assessing fully. And then again, that continuous evaluation of client safety, suicidal risk, suicidal ideation, homicide, just looking at those safety mechanisms for your client because we always want to, be assessing for that. There was a great list. You will find his the DOI in my references, but he had a good list of assessments that they were so numerous that I didn't include them on here. But if you were looking for a good list of evidence-based assessments, you could find that within his article. So major depressive disorder increases when there is evidence of negative affectivity. So what that means is that you see that clients have negativity as a repeated response to their life stressors. So an individual may come with fears of being alone or rejected, just having those fears in general. And so when there's a life stressor, the fear of abandonment may be more difficult to overcome. So, that risk increases then. It increases when there's a history of exposure to extreme childhood stressors. and, trauma, all of that. So just again, going back to that history of the client. Parents, so MDD increases when parents or first degree relatives suffer from it. And so, I mentioned that it's very important to get the parent history as well to see if MDD, if the client has a risk at, suffering from MDD. And last, from our textbook, individuals suffer, or MDD increases when individuals suffer from any mental disorders or certain medical disorders. So our textbook states that substance use, anxiety, and borderline personality are examples of when MDD may start in the background of other disorders. Chronic or disability medical conditions also increase NDD. So diabetes, morbid obesity, cardiovascular disease. So this is some risks to look out for with MDD. I know this slide looks like a lot, but I thought it was so important. I read this article, this study. The DOI is again in my references, but Klarman and Weisman found that clients who jump into MDD had prior depressive episodes that and that maybe they're just not getting diagnosed immediately. And so they stated that maybe it just doesn't come out of the blue, and that there's a higher prevalence of depressive symptoms that do not meet the criteria that we discussed earlier. And so, one of their studies discussed that 50% of the first onsets of major depression over the year were attributable to prior depressive symptoms. So again, in the assessment, I said, should include a client's history, especially with depressive symptoms, because it could mean that they're more at risk for MDD. And then, Grobler stated that, those who experience MDD will have a lifelong course of the illness and reoccurring episodes without full recovery. He even discussed that clients may suffer from double depression. And so I think it's just, important to just gather that evidence. So he talked about double depression as a concurrent with major depression and other disorders. So it seems that, those who suffer with MDD may not always get better, but we'll talk about, some ways to kind of help your clients going through MDD. This is a big, stat here, 9 to 24%. But I thought it was important to note that with the initial diagnosis of MDD, clients will undergo a change in diagnosis over time, mostly when move into bipolar disorder. So again, just other risks worth noting beyond our textbook with MDD. Moving into the ethical considerations, as practicing clinicians, it's important for us to know our code of ethics. And so all information with clients in MDD should be confidential, except when the disclosure is required to protect clients or identify others from serious or foreseeable harm, or when legal requirements demand that confidential information must be revealed. So this is the same across the board with any, disability, but with the stats on suicidal risk, it's important to note that it is confidential unless, we have, if a client, is talking about self-harmed himself or others. And so we are then required by law to report that. If the professional determines, I added the Texas State Code. I practice in Austin, Texas. And so it's kind of the same as that, that if there's probability of immediate mental or emotional injury to patient, by the patient or to others. Professionals must disclose this information to someone in the written consent file, parent or guardian, if it's a minor, or other professionals, law or medical, police or higher form of care to support the client appropriately. Going back to client safety is the number one thing, advocating for that client and their higher forms of care if needed. So, minors is such um, an ethical dilemma and consideration that we need to take into thought. So, age and those, I'm going to dedicate a couple slides to that. So, in terms of our code of ethics, when counseling minors and adults who lack the capacity to give voluntary consent to release confidential information, counselors seek appropriate permission from third party to disclose the information. In such instances, counselors inform clients consistent with their level of understanding and take appropriate measures to safeguard confidentiality. So how does that impact DDD? Well, or MDD? MDD. We always need to inform our clients on their level of understanding, but it may be important to also inform their guardians or their third parties. Those facts about depression, the commonality of it, the certain criteria that your client fits for major depression disorder, and the assessments being used, as well as the treatment options. So, we need to keep everyone informed. Um, you know, so it's important to consider that. Again, I threw on the Texas state law here. It is important for you to know your law. And so I encourage you to look that up if you had some time to just know what this means for minors. For example, in Texas, a child may consent to counseling if it had to do with suicide prevention. So there's other reasons, but in particular with MDD, since that discussion of self-harm seems to be higher and suicide has high rates, within minors, it's very important to know your rights in terms of counseling. And so that is something that I kind of wanted to add to that slide. Other considerations, life factors. How important are these factors in your client? So really knowing how these factors influence your client are important to determining, MDD in their life. So cultural influences, complexity of the client's cultural identity, gender, socioeconomic status, social class, geography, race, religion, politics, all can increase MDD. So consider their symptoms, but also be sensitive to these life factors. Again, more age and sex, just this may be more of a risk, but just knowing or taking into consideration that MDD can begin at any age, but the first episode may be mild and untreated. This was taken from Grobler. The highest proportion of cases occurring between 25 and 34 years old. And so it's where, if you have clients at that age suffering from MDD, it's important to consider that. There are two peaks, Grobler stated, in the 20s and 40s, but the estimated mean route age is 30. And women are more impacted with depression and MDD than men. And that was in actually multiple sources. Considerations with those in poverty and geographical locations. So 76 to 85% of people in low and middle income countries receive no treatment for their disorder. And I put why. Well, those in poverty actually could lack the resources, the healthcare resources, the healthcare provider to get actually diagnosed. So it's not that they're not fitting the criteria, but they don't have the correct resources. And then talking about the stigma from, the beginning of history, people may not be so quick to jump in and getting diagnosed. There is that social stigma, and I know we had those discussion on labels and is it good for the client to have a label? And so, those things can be going into why certain people are not getting treatment for their disorder. Also, I read in this article that regions in conflict had higher prevalence than those with no conflict. And, that kind of is self explanatory that if there's more going on, individuals may be more at risk for MDD. And so a lot of this is taken from the World Health Organization. A lot of those statistics were too. So, um, moving into immigrants and ethnic minorities, again, World Health Organization, our textbook really discussed this. Immigrants may be struggling with conflict of values from their country of origin and transferring those into American customs and values. It could be a language difference, parenting stress, conflict between children's and parents' beliefs and customs. Saw this a lot when I worked in the school districts of, children being born here versus parents immigrating here. Parents really wanted to keep their beliefs, customs, and language alive, but then children, born here are getting those American customs. So there could be, some depression within parents of losing, their heritage and their customs that are important to them. Ethnic minority groups, contextual stressors like poverty, poor, rundown neighborhoods, acculturation, and loss of never going home again. So maybe just those depressed feelings. We talked about life stressors. So definitely immigrating here is a huge life stressor. And so it's very important to consider all of these things when dealing with clients and MDD. The World Health Organization actually, talked about prevention programs, and I thought it was kind of cool to put that here that, these could kind of help people within the community. And so I thought, why not put it there when considering your client, thinking about some prevention programs. Oh, self-care. I'm definitely an advocate for self-care. It's so important for us in our line of work, but also with our clients. I read, from Grobler that it may not go away. And so maybe these are some things we can kind of discuss with our clients. This is all taken from 10 self-care strategies, not so much evidence-based, but I thought they were kind of interesting care strategies. And she stated, I've come to realize that self care isn't a brilliant epiphany or a single life improving hack. Rather, it's a series of small choices that add up to a healthier lifestyle. So, Marlo herself actually deals with MDD and struggles from it. So, she kind of discussed 10 different strategies, taking better care of yourself where I am, looking at where you are and how can your client take care of themselves. So she stated it was more of a perspective of looking inside. Mental illness is a part of my life. So I developed coping strategies that I can use throughout the day, paying closer attention to what is happening in her body. And so, really helping your client work through the body, maybe some CBT, how they feel physically and emotionally, clues that maybe that's time to give yourself some rest, grace or attention. Talking about deep breathing strategies, breath work can be used every day. It increases circulation, releases endorphins, relaxes muscles. I'll talk about kind of a mindfulness study. So obviously may not cure depression, or MDD, just things that, to take into consideration with clients. I try to notice one thing I like about myself. So being okay with your appearance, acknowledging the thoughts that a client has about self, but, maybe sending in a couple messages, a couple affirmations, compassion to self. She really began to get familiar with the feelings and the thoughts going through her head, the negative tape, she called it. So she, became aware of those thoughts. Um, our EBT really helps with that as well. And then she noticed where she can do things to bring into her daily moment. What can I do to bring into my life now? What can I do? Can I go take a walk? I think she talks about walking her dog, but maybe that's not something your clients do. Maybe they sing, or maybe they like to draw or write. Can they bring that into their daily lives? And then communicating with people around them, noticing the feelings and discussing, like, hey, I need to go outside for a moment, or kind of sharing with them, giving them permission to do the same. And then she adds in finding something fun to lift her spirits. Again, that could be coloring, dancing, singing, cooking, really anything that your client shows an interest in, maybe encouraging them to do that for 10 minutes a day or even smaller. She talks about a sleep routine that really helps getting that first night, or that beneficial night's sleep, especially for those dealing with insomnia, talking about some good strategies, like having no combos or putting the phone away at a certain time. There's certain meditations or oils, kind of just to help your clients wind down. And then she talks about oils, scents to stimulate the senses and the mind, helping them come back to present moment. So those are some little considerations I thought I'd add, kind of a fun slide to think about. These are just good things to do in general, even if you're not struggling with MDD. I think it's some good healthcare strategies. So now moving back into evidence, here are some evidence-based treatments that were discussed. I threw in our ASCA code of ethic that when providing services, counselors use techniques, procedures, modalities that have been grounded in theory and or have empirical or scientific foundation. So it's based on levels of severity with depression, mild, moderate, severe. There should be that therapeutic alliance. I know our theories book really discuss therapeutic alliance, non-judgmental, safe, built on confidentiality, open acceptance, all of those things. So that way, the client, is understanding of what you have to say regarding MDD, and educating the client on the different things that come with MDD. The criteria is, again, different assessments, the treatment options. So important within that therapeutic alliance. CBT, looking at thoughts and how they cause behaviors, a lot of evidence with depression and CBT. I know I love REBT, rational emotional behavior therapy. So that's something kind of like a little umbrella term that fits under behavior therapies. Interpersonal psychotherapy, electroconvulsive therapy for severe depression. Grobler actually stated that this is, something for severe depression. I have not read too much into it, but that was something he discussed. Pharmacological therapy, which is just a beautiful term of medical treatment by means of drugs. So, we do have antidepressant medications. There's a good table that he has in his article to show the different types of medications. And he did report that in a study that people struggling with MDD had shorter episodes on medication. So again, looking at the severity is important with determining the intervention and the different modalities. So, it could be all, or it could be one, or it could be both, really looking at your client and their needs. I'm into mindfulness. And so I looked up this article this study really caught my attention. But its findings were very good to hear for my practice. Meditation for depression. Basically, they called it a standardized training program that combines cognitive therapy and mindfulness meditation. So, mindfulness meaning mind body technique, training the mind through regulation of attention and emotion to affect body function, symptoms, and state of being. And so that's a definition they use within their article. But basically, it was a review summarizing current evidence for randomized controlled trials, testing the efficacy and safety of mindfulness. Oops, that should be MBCT for patients diagnosed with MDD. So they were looking at, does MBCT as alone, as a monotherapy, reduce symptoms among those depressed or among those with a history of depression to reduce relapse? Because we do know that, individuals struggling with MDD may relapse, or, could relapse. And so they really wanted to see if this therapy by standing alone helped reduce that. Um, and they found that in the use of monotherapy and BCT, further exploration is warranted, that the evidence supports that the use of adjunctive MBCT to reduce depressive symptoms among current episodes should be used with should be used as a supplement with other things, maybe some things that we discussed in the previous list, but they were saying that it should be supplemental, that, further exploration is warranted to determine this, that they couldn't rule out that this is the best treatment for all. The evidence supports that supplemental NBCT to reduce relapse among those currently depressed or among those with a history of at least 3 previous episodes. Again, this should be used in supplement. So, just some things with that, all that self care, great supplements to help those suffering with MDD. Here is my reference list. It is available for you, a lot of great references, but this is basically my presentation on major depressive episodes. Feel free to reach out if you have any questions or concerns. All right, thank you.